Okay, thank you. Well, the good news is pregnant women in general are healthier than most of our ICU patients. But I think the downside is that we now have older mothers and more complicated pregnancies, so we may actually be seeing more than we wish to see. I have no conflicts in relation to this presentation. So let's start with a question. Talking about physiology of pregnancy, which one of the following increases in pregnancy? Systemic vascular resistance, functional residual capacity, AST and ALT, chest wall compliance, or cardiac output. So which one increases? Okay, good. This was an easy one to start off with. Cardiac output increases. Now, you always read in books and literature about these physiologic changes, and they are important to understand because they do impact how these women will present with some of the more critical conditions that you're going to deal with. So from the cardiovascular side, blood volume increases. Cardiac output increases. In the first 2 trimesters, that's primarily a result of increase in stroke volume. In the last trimester, there's also an increase in heart rate. Blood pressure goes down, primarily the diastolic, due to a decrease in systemic vascular resistance, with the lowest blood pressure in the second trimester. Filling pressures are unchanged. And oxygen delivery, of course, as cardiac output goes up, will also go up. Now, all of these changes are meant to deliver nutrients to the fetus at the same time maintaining the maternal status. So it's kind of doing feeding the two, eating for the two, so to speak, but it's delivery of oxygen in this case. From a respiratory standpoint, minute ventilation goes up, both tidal volume and particularly in the last trimester, respiratory rate. This is the group of patients who will have a compensated respiratory alkalosis. Their pH can actually come almost back to normal. The PCO2 that you would expect in a pregnant woman is about 30 to 32. Functional residual capacity goes down, particularly in the last trimester. The AA gradient really does not change in the sitting position. There may be some changes in the supine position. Chest wall compliance decreases by about 40%, but lung compliance is normal. So it's chest wall compliance, and that's due to the spreading of the thoracic cage as the uterus expands. The airway edema is worse in the pregnant woman, which will impact sometimes the intubation preparations that you make. GI, of course, the lower esophageal sphincter pressure decreases. The hepatic enzymes will actually decrease. They're usually about 20% lower than normal, and of course they'll just read normal when you get your lab results. Hematologically, you'll get a dilutional anemia because the red cell mass increases, but the plasma volume increases more, about 40 to 60% versus about 25 to 30%. So you will have a dilutional anemia. White blood cell count is often slightly elevated. And there is an increase in all clotting factors, but your laboratory test will be normal. But it's important to recognize because of the increase in coagulation and thrombotic risks that occur in these patients. Let's start off with hypertensive disorders. This is the number one cause of maternal mortality in the United States. If you look at most countries, it's either bleeding first, usually hemorrhage, and then hypertensive disorders. In the U.S., it's now kind of hypertensive disorders taking over. Of course, there's several types of hypertension. Pregnancy-induced hypertension is hypertension without proteinuria, essential hypertension, but the ones that we're really concerned about are really severe preeclampsia and eclampsia in this group of patients. Now, preeclampsia is defined as the onset of hypertension after 20 weeks gestation, blood pressure greater than 140/90 with proteinuria. Edema is not required for the definition of this condition. We'll talk about some of the criteria of severe preeclampsia on the next slide. And eclampsia is basically preeclampsia with seizures. Now, eclampsia often occurs before delivery or during delivery, but it can occur up to 2 weeks after to delivery. So this is where you might get into trouble if you don't think about this in the postpartum patient. Now, severe preeclampsia is what the majority of our patients that come into the ICU are probably going to have. And this is an exaggeration of some of the definitions. So the blood pressure will be higher, 160 over 110. Proteinuria will be greater. And they may actually have a lower blood pressure, but if they have any of the systemic symptoms, it will put them in the category of severe preeclampsia. And if you look at the list, basically this is multi-organ dysfunction. So this can impact the lungs, the brain, the liver, and the coagulation system as well. Now, the management, of course, is with severe preeclampsia or eclampsia is to admit the patient to the hospital and then the decision about whether to deliver the fetus. And this usually requires a maternal-fetal expert to help you with this, but it depends on the age of the fetus. If it's greater than 34 weeks, they will usually deliver. The status of the fetus, if the fetus is already in trouble, they may go ahead and attempt delivery, and also the status of the mother, obviously. If the mother is not doing well, the fetus will not do well. Monitoring is initiated for both the mother and the fetus. And then the two mainstays that we're going to talk about are seizure prophylaxis and blood pressure control. In the setting of oliguria, you should give fluids. You should never give diuretics to a patient with severe preeclampsia because they are usually intravascularly volume depleted, very similar to other hypertensive emergency type patients. So fluids in oliguria. For seizure prophylaxis, the treatment is magnesium sulfate. Magnesium sulfate, after the MAGPIE trial, is very well established. It will decrease the progression to eclampsia by over 50%, and it also decreases maternal mortality. IV is probably the more humane way to give it than IM to your patients. And the loading dose is about 4 to 6 grams, and then you can give an infusion. You're aiming for a magnesium level of 4 to 7. And, of course, you have to have appropriate monitoring for potential overdose or exaggerated effects on the respiratory status. Now, the actual indications for instituting magnesium sulfate are somewhat variable. In general, people have said diastolic greater than 100, but you may see some recommendations that say greater than 105 or greater than 110. But if you have a lower blood pressure and you have signs of severe preeclampsia, most would say go ahead and start magnesium. And if you develop preeclampsia during labor, then, of course, that's another indication. Blood pressure control is basically similar to the approach you would take with a hypertensive emergency in a non-pregnant individual. You want to decrease the diastolic to about 90 to 100, but not to normal in these patients. Traditionally, the medication of choice was hydralazine. I would say today you might more likely see labetalol. In studies that have been done, hydralazine and labetalol were equivalent. Only thing was there was more bradycardia in the neonates with use of labetalol. Now, in the U.S., you probably won't see the use of oral nifedipine, but it has actually been well established and is used in developing countries. IV nicardipine has similar outcomes as labetalol. What you definitely want to avoid are ACE inhibitors, nitroprusside, if at all possible, and again, diuretics are not indicated for these patients. Now, the HELP syndrome is often seen as part of a spectrum of severe preeclampsia or eclampsia, but it actually is a distinct entity, although the lines do get blurry. Remember, the HELP stands for hemolysis. It's a microangiopathic hemolysis, elevated liver enzymes. And if you use the LDH for the hemolysis, you can't use it here, but that's usually not a problem because if you have hemolysis, your AST is going to be elevated too. And a low platelet count, less than 150,000. Some have used less than 100,000, but I think the more standard would be less than 150,000. Whereas severe preeclampsia or preeclampsia in general is a syndrome of first pregnancies, HELP is a syndrome of multiparous women, although there is crossover. HELP syndrome is usually in the last trimester, but it can occur after delivery. It does occur in about anywhere from about 10 to 40% of patients who have severe preeclampsia. One of the issues here is that hypertension is not as severe and it's absent in about 20% of those with HELP syndrome. So that is not as strong a feature of this syndrome. In general, because of the increase in mortality in this syndrome, urgent delivery is usually recommended and accomplished. Same type of care, magnesium sulfate for hypertension, and blood pressure control, similar to what you would do in the patient with severe preeclampsia. Now, the other interesting thing is that you may see people that have recommended plasmapheresis. Really and truly, plasmapheresis should only be undertaken if you think the patient has TTP. And there is an overlap here as well, and I'll show you how this can some recommendations. Dexamethasone has been used in some obstetrical centers with the assumption that it improves some of the outcomes, but a randomized clinical trial actually showed that there was no benefit. But you may still see your maternal-fetal people recommending this. In HELP syndrome, one of the things that is really devastating are some of the complications, particularly hepatic rupture. As you can see here, there's blood here around the liver, and renal failure that is often a problem. Whoops. Can we go back? Okay, TTP in pregnancy. TTP occurs in pregnant women. Up to 30% of TTP cases are in pregnant women. And there is an overlap of the symptoms, but some of the things that you can look at, hypertension is not as typical with TTP as with HELP or preeclampsia. Abnormal LFTs are less common. In other words, they still have microangiopathic hemolysis, but less liver function abnormalities. Mental status changes are more likely in TTP than in severe preeclampsia. DIC is not a characteristic of TTP. It can be seen in severe preeclampsia and in the HELP syndrome. One of the other clues is that if the syndrome, this hemolysis, doesn't resolve after delivery, that makes it more likely that it might be TTP. So if you're thinking TTP, steroids, and this may be where dexamethasone appeared to have some effects in the past. What they may have been treating was TTP rather than HELP. And if you are considering TTP, then plasma exchange, of course. And again, the clues here are the syndrome happens after delivery or the failure to resolve after delivery. Well, hemorrhagic shock or bleeding in pregnancy is, again, the second leading cause of maternal mortality in the U.S. It's the number one leading cause of mortality in most other countries. And this is defined, significant hemorrhage in pregnancy is defined as a greater than a liter of blood loss. And several etiologies, we can't go through all of these, but placenta previa, the hallmark here is painless vaginal bleeding. And again, transfuse these patients. They can often stabilize them, but these require an operative delivery because this is implantation of the placenta over the os, or at least partially occluding the os. Placental abruption is associated with hypertension in multiparous women, particularly, and older women. And by the way, older is considered greater than 35 here. I don't agree with that, but that's the definition in the pregnant population. In placental abruption, it usually means delivery, and this is associated with a high incidence of DIC in these ladies. And, of course, ectopic pregnancy as well, associated with hemorrhage. Trauma, uterine rupture, you just got to get these people to surgery. Now, uterine inversion, again, uterine atony, there are things that can be done, particularly with uterine atony. They can massage the uterus. We give oxytocin to these individuals, retain placenta. It's source control here, get the placenta out. Now, peripartum cardiomyopathy is often asked in some form or fashion on some of the board exams. It's defined as cardiomyopathy that occurs in the last month of pregnancy to 5 months postpartum. The majority recur after delivery, 80 to 90% after delivery. It looks exactly like any other form of heart failure. The EF, by definition, has to be less than 45%, and with no other reason for that. In other words, I can't have coronary artery disease or suspected coronary artery disease. Management is very similar. Again, you have to avoid ACE inhibitors prior to delivery. After delivery, give all the ACE inhibitors you want. There's a high rate of thrombosis, up to 50%, so some people would recommend anticoagulating these women. Mortality is about 25 to 50%, so it's a very high rate of mortality. About 50% of these women will resolve their cardiomyopathy. In this concerned that this might be mediated by some autoimmune phenomena. Some have recommended immunosuppression, and these women are certainly candidates for a potential transplant. Okay, this is a pregnant woman at 34 weeks gestation who's a restrained passenger in a motor vehicle accident. On arrival, she's lethargic on a backboard with a C-collar in place. Blood pressure is 70/40, heart rate is 110, respiratory rate 20. Which of the following is the most appropriate initial intervention? Transfusion of Rh negative blood, emergent operative delivery, intubation and mechanical ventilation, elevation of the right hip, or 2 liters Ringer's lactate and dopamine. Great. 57% of you got the right answer, which is to elevate the hip. And again, this is the initial intervention that we're talking about. This particular individual may go on to need blood transfusion, but that's not going to happen that quickly. So this is the supine hypotensive syndrome of pregnancy. This is a last trimester phenomena. Could happen a little bit sooner, but particularly in the last trimester, where compression of the IVC decreases venous return and also increases afterload, and the venous return decreases by about 25 to 30%. So the first thing to do is get the uterus off of the IVC. So the left lateral decubitus position or elevation of the hip, about 4 to 8 centimeters is what is recommended. For emergent transfusion, Rh negative blood is the product of choice. Monitoring, even in the setting of minor trauma of the fetus, needs to occur for at least 4 hours. You should do needed x-rays, but shielding, of course, is appropriate. And even in the setting of minor trauma, it's recommended for those women who are Rh negative to go ahead and get treated with Rh immune globulin. The Kleihauer-Betke test you can get your pathologist to help you with, but the current recommendations are that you go ahead and treat, because it doesn't have to be obvious blood loss. They've actually found fetal blood cells in the maternal circulation, even in the setting of minor trauma. So don't forget about that in your patients. What about cardiac arrest? This is devastating in the pregnant woman. You elevate the right hip. You may have to displace the left breast in order to defibrillate and place the pads in the appropriate position. But if there is no indication of quick recovery, then if you're thinking about a cesarean delivery, it needs to be done within 4 to 5 minutes of arrest. Here the goal is to improve the maternal circulation. Okay, it's not to necessarily save the fetus, it's to save the life of the mother. Mechanical ventilation, respiratory issues. Remember, we talked about airway edema, so you may need to choose, if you have to intubate a pregnant woman, a smaller endotracheal tube, a 7 instead of an 8, maybe a 6.5 instead of a 7. Your goal here is to keep your saturations high on the higher side, greater than 94%, to ensure delivery of oxygen to the fetus. PCO2, we're going to aim for 30 to 32. If your patient already has a PCO2 of 38, that's actually an indication of ventilatory failure. Hypercapnia, the safety is not really known in the pregnant individual, but if you were forced to use it, then you obviously would have to do that. High airway pressures in these patients, particularly in the last trimester, do not necessarily indicate high alveolar pressures. Again, this has to do with compliance of the thoracic cage. Non-invasive ventilation in general is not recommended, although it is used in the pregnant population, but you have to be concerned about a higher risk of vomiting and the potential for aspiration. And as far as ventilator changes, we're used to looking at our patients and all the things, but here you also have to monitor what those effects might be on the fetus. Tocolytic-associated pulmonary edema, it doesn't occur that commonly. It probably occurs more commonly on board exams than it does in maybe in your patients, but at least be aware of this. It occurs with beta agonists. Ritodrine, terbutaline is probably the most common, and recent look at this suggested that terbutaline plus magnesium sulfate is where we tended to see it more. The etiology may have to do with hypervolemia, capillary permeability, or even cardiogenic hydrostatic causes. The treatment of choice is to stop the tocolytic. Most of these women do not require intubation. Diuretics do seem to help in these situations. And actually, this is an entity where non-invasive ventilation has been used because the treatment is fairly rapidly able to turn these women around. Okay, it's not. Can you advance the slide? It's not going. Thank you. Asthma. Most of the women with asthma, the exacerbations tend to occur in the second trimester. There is an increased risk of pregnancy complications, and the management is basically the same. Inhaled agents are preferred. Systemic steroids are safe. Aminophylline in very severe cases can be used. If you're using systemic steroids, then the need for covering with steroids at the time of delivery needs to be considered in those patients. Okay, which one of the following suggests the diagnosis of amniotic fluid embolism rather than venous air embolism? Sudden cardiovascular collapse, occurrence during labor, diffuse pulmonary infiltrates, disseminated intravascular coagulation. So basically, which one is more likely with amniotic fluid embolism than venous air embolism? Oh, good. 58% of you got the right answer. And this is always a fun question because it makes you think about these entities. Amniotic, they both present with cardiovascular collapse. And it's sudden, and it's often during labor or immediately post-labor. Venous air embolisms can occur with cesarean sections, abortions. Amniotic fluid embolisms can occur with abortions as well. The hallmark difference here is DIC, which is very, very common with amniotic fluid embolism. In fact, these women can actually present with acute onset of diffuse bleeding before some of the cardiovascular collapse. The treatment of choice here is to evacuate the uterus if that has not already been done for amniotic fluid embolism. Steroids are not known to be beneficial. I've seen people give them, but they're really not known to help. For venous air embolism, the hallmark, they might give you that mill-wheel murmur over the precordium in a case scenario. Left lateral decubitus position, although some have questioned the benefit of that. If you had a central catheter in, you can try to suck air out, but basically you're trying to avoid outflow obstruction on the right side of the heart. 100% oxygen, and for significant cardiovascular or CNS morbidity, hyperbaric oxygen has been recommended, although, again, there's no evidence, no real clinical trials, mostly just based on the severity of the outcomes in these individuals. Thromboembolic disease, remember, all the pregnant women are at increased risk of thrombosis because of the increase in coagulation factors. DVTs are about 3 times as common as PEs. But all of these are about a 5-fold increase in this population. Pulmonary emboli present with the same type of symptoms. VQ scanning is reliable. Most of the diagnostic study recommendations are extrapolations from trials in non-pregnant women, so you need to keep that in mind. Angiography is the gold standard. There's really very limited data on the use of spiral CT in the pregnant individual, and of course that is a high level of radiation exposure. D-dimer levels are not helpful in the pregnant woman because after 16 weeks they're elevated. So you can't use D-dimer in these women. DVTs, they can be pelvic, iliofemoral. Pelvic veins may not be easy to thrombosis may not be easy to diagnose. 90% occur in the left leg. Now, a lot of these women get a lot of studies because they get swelling of their legs. They actually have a higher rate of negative studies than other populations. But Doppler ultrasound is probably the most commonly used. Venography is not used really that often, and serial Dopplers are helpful for equivocal results from your first exam. Okay, so a woman at 28 weeks gestation is diagnosed with a left iliofemoral thrombus, and your decision is made to treat with low molecular weight heparin. So which of the following is the most correct regarding treatment dose of low molecular weight heparin? A, the dose will remain the same as the non-pregnant woman. B, the dose will need to be higher than a non-pregnant woman. C, the dose will need to be lower than a non-pregnant woman. You only get 3 choices here. Okay, the answer is B. Gotcha. Okay. There is increased renal clearance of low molecular weight heparins in the pregnant woman. So in general, you need to start with a higher dose. Instead of 1 milligram per kilogram, it's 1.2 milligram per kilogram every 12 hours. And some would say that you should monitor anti-factor 10A levels in these individuals to make sure you have adequate anticoagulation. So the treatment of choice is heparin. Unfractionated or low molecular weight heparin, both can be used. In general, you'll see low molecular weight heparin, particularly if these women are at home and not ready to deliver. Coumadin is contraindicated in the first trimester, absolutely. Relative contraindication in the last 2 trimesters. In the setting of a PE with hemodynamic instability, thrombolytics can be given. And again, there's no data that says it's going to improve outcomes, but it certainly may be a last resort. Treatment is continued at least 6 weeks postpartum or for a total of 3 months in this population. Last thing, a couple of things to just mention, acute fatty liver. This is a devastating condition. It occurs in the last trimester, very fulminant. It is very distinct from the cholestasis of the pregnant woman, which is a benign. Here you'll see all the classic features of hepatic failure. So they'll be hypoglycemic, they'll be encephalopathic with high ammonia levels. Their transaminases are higher than you would see in the HELP syndrome or in severe preeclampsia. And the treatment of choice here is to terminate the pregnancy in order to save the mother. And the last thing is just to again, a few words about drugs in pregnancy. Always look up the category. Always look up these if you're going to treat your patients. But in reality, if you have to use a drug to save the mother's life, then you need to do that. Just keep in mind, you might want to get your clinical pharmacist to help you because the volume of distribution is much greater in the pregnant woman, and their GFR is higher, so dosing of some drugs may need to be altered. And again, just reiterate, ACE inhibitors, no. Barbiturates, no. That's not usually a problem. Warfarins, no. Quinolones, no. Those are kind of malpractice issues you don't want to get involved with. And as a general rule, avoid drugs that decrease placental blood flow for maintaining oxygen delivery to the individual fetus. Okay. Thank you very much. And I'll give you 2 minutes extra here.